Good afternoon, everybody. My name is Laura Appleby. I'm presenting on behalf of the Partnership for Child Development, which is based here at St Mary's and is also a member of the London Centre for NTD Research, also with a focus here in St Mary's. PCD really works kind of more about putting a lot of the evidence into action, and how do we really look at global health from a kind of from a perspective of actually enacting some of these things. The other thing that we do is really we're at the nexus of kind of health and education. So a lot of what we do is looking at simple, safe, effective interventions that can be implemented from a school-based platform. Today I'll be presenting some of that, and in particular the school as a platform for helminth control, and how this can also help support a lot of the global goals for NTD control. So as I say, the school is an effective platform, and this kind of picture really shows a lot of that in a nice kind of graphic. And I'm not going to focus on talk about much of this today, but what you can see here is the school is really the heart of the community. There's a lot of things going on at the school. There's a lot of children attending school, and there's actually more children surviving childhood today than ever before, and there's more children enrolled in schools around the world than ever before. It also provides a good, stable way to reach a multitude of people, not just the children, but also community members and the teachers, via harnessing a lot of the educational resources and what education can provide. And this includes using teachers who can often serve to support a lot of those health interventions and even distribute certain treatments in some situations. So really today we're interested in this bit down here, the deworming, and how we can really target the greatest number of people for the greatest effect. When I'm talking about deworming, I'm talking about soil-transmitted helminths, really Ascaris, Trichuris, and hookworm. As I mentioned earlier, children are surviving childhood. They're surviving, if they survive through the incidences of diarrhea, through cerebral malaria, they're getting into schools. That doesn't mean that they're free and clear, and actually there's a lot of infections that can really detriment a growing child and prevent them from attending school, and prevent them from actually uptaking a lot of that education. So it's really looking at kind of the win-win for education as well as for health from this. And a lot of the evidence does show that deworming can significantly impact on health, on nutrition, education, and long-term development and productivity. In terms of access to education, deworming has been shown to increase attendance by as much as 25%. And in terms of quality, deworming improves the child's ability to actually absorb the education which is on offer. So the global situation and the global goals situation is over 1 billion people worldwide are affected by these soil-transmitted helminths, and over 600 million school-aged children are actually at risk of infection. And this has a massive impact actually on school attendance, with between 200 to 500 million school days estimated to be lost in the low and middle income countries due to many health problems, but as well these worm infections, which are very prevalent in poorer countries without much in the way of resources. As far as the WHO is looking at the moment, their NTD roadmap for implementation their vision is a world free of childhood morbidity due to STH by 2020. And the goals here are to cover 75% of preschool and school-aged children who are in need and at risk of infection, and to ensure that they're regularly treated, and to make sure that coverage is achieved in 100% of the countries that have STH as an issue, and to reduce prevalence of moderate and high intensity infections among school-aged children to below 1%. And I should also mention here that with STH, infection intensity is directly related to morbidity. So if you can bring down the infection intensity, you can actually significantly impact on the morbidity felt there. The Sustainable Development Goal, SDG 3, good health and well-being, has one goal as being specifically to end the epidemics of AIDS, TB, malaria, and NTDs by 2030. And the indicator here is to address, it's the number of people actually receiving treatment for these NTDs. So I should say as well, the treatment for STH is with benzimidazole, so it's treatment with albendazole or mebendazole. This is what the WHO recommends, and treatment can be distributed as part of mass drug administration, so it's not selective treatment. It's safe to provide treatment to people even if they are not infected. And the WHO actually recommends treatment via schools in order to reach the most number of people who are likely to be suffering from severe morbidity in a very cost-efficient and cost-effective manner. So with these drugs going to scale, how do we really make sure that we are strategically targeting these programs? How do we make sure that we can leverage as much of the resources that are available in an effective manner? And how do we mainstream all of this as well? So as an example of strategic targeting, this is some work we did in collaboration with the Global Atlas for Helminth Infections. And just as an example, there's some of these maps that were developed in Kenya, and they're based primarily on publications that have been done in very small scale parts around the country, and over 850 publications were assessed and plotted on a map here, and you can see the areas of darker red are the areas of a higher prevalence. You overlay this with climatic data, with vegetative data, and you can come up with a predictive risk map showing the hotspots of transmission where you'd expect transmission to be occurring. And that really helps governments understand if they're going to a national program, where do they need to target these interventions. And specifically and effectively here, what was happening is there was, prior to the availability of this map, there was a huge amount of deworming happening in the north of Kenya. Knowing where the transmission is actually happening and where the risk is really allows the resources to be focused in on the areas that need it the most. So everything that was being distributed and sent to the north could be focused much more on the south for a greater impact in that as well. So, and one of the things as well, when you're talking about the costs of a program and how to get the most out of kind of the input, is to know how much it's going to cost. And when we're talking about education does have a huge amount of resources available, but they need to know how much they need to cost these programs out, how much budget they need to set aside in order to start addressing this. So this is one of the areas we've really been trying to support in various countries. An example here is from a program also from Ethiopia in the south, where we've been supporting an integrated program in order to not just address deworming, but how can we really improve education and health through provision of daily school meals, which really support with addressing hunger, as well as nutrition and nutritional deficiencies, as well as providing synergistic interventions such as water and sanitation to support preventing reinfection. So this is an example of the integrated costings that we got and the proportion of what each of these interventions was actually taking up. And as you can see here, a real cost driver was actually the recurring cost of food. And the deworming part of it was all coming under here, the transport, the monitoring, direct cost in training and awareness. And it's not even the full pie. So the deworming here, we can state quite clearly that it's 40 cents per child per year, and that's primarily made up of transport and salary costs. So the benefit here is that the government in Ethiopia is rolling out a national school feeding program. That's going to cost the government $32 per child per year to provide those meals. For 40 cents extra, you can add on deworming and really address that issue as well, and ensure that the child is really benefiting the most from this intervention. Now, when we're talking about integrating, so we can really harness the combined activities that might be happening. Maybe we need to train teachers for multiple activities at once. Can you join the monitoring in this? Can you join the storage? The cost savings, and this was across 30 schools in southern Ethiopia. If we address that across all 375 schools in the region, it's a cost saving of $61,760, which is, when you can go to the government with this kind of actual fact and figure, they can actually start to do something about it and feel quite engaged as well. I think I've shown that one, have I? No. So yeah, this is just to show that the delivery cost for deworming via a school-based activity really can be driven down quite cheaply when you compare it to the other kind of distribution methods, such as mobile health teams or community-based deworming, which is a magnitude higher in terms of cost. And what we're seeing here is that as far as school health and nutrition, which is just any kind of program which you can deliver from the school platform, we're seeing more and more governments are really absorbing this as an activity. Education sector especially is absorbing this and considering it as part of their own activities and mainstreaming this. And once you have these programs actually institutionalized and mainstreamed, they will occur year after year. And as you'll see, that's quite important in the case of something like deworming. This sample is including 25 countries across sub-Saharan Africa, and every single one of those 25 countries as of 2015 was actually including some element of health into their education sector plan. And education across the board is actually, they do have budget. It is a restrained budget. It's not something they can just throw out and cost up and afford everything. But if you can show them the benefits of actually investing in the health of the school children and how that is going to benefit their education in the long run, you can really start to engage in there. In Ethiopia, I know that the education sector, their financial budget is worth a quarter of the national budget. So there's a huge amount of resources right there, and if they can go a little ways to supporting some of these health issues, they can really have a much larger impact and serve to actually support the health sector, which is often overburdened in terms of trying to address the under 5 health and maternal health, leishmaniasis, perhaps. So it's a resource that we should really think about keying into. Another thing that is very key in terms of scaling up these programs is in 2012 the London Declaration on NTDs, and this was a fantastic commitment by multiple pharmaceuticals, big financial donors, governments, NGOs to really collectively start looking at how can we address neglected tropical diseases on a global scale. And here we've got 2 key points, which are to sustain, expand and extend drug access to ensure the necessary supply of drugs and other interventions to help control by 2020 various of these key NTDs, and to enhance collaboration and coordination as well. So Ethiopia, again, I'll keep drawing back on that, but they do have a national NTD program and an NTD plan and strategy, and that is across all the NTDs. And it's really quite impressive what they're achieving there. As well, the pharmaceuticals gathered together and actually pledged to donate a huge amount of drugs that are necessary in order to treat these NTDs and to control them. In 2015 alone, 2.4 billion treatments were donated, and specifically for soil-transmitted helminths, 390 million tablets were donated, which is just a huge effort. 2017, there was the kind of 5-year anniversary, and these pharmaceuticals again pledged to support this kind of worthy cause. And it's having an impact. So this is the change in coverage for STH between 2003 and up to 2015. And key here is this up here in this blue line and white diamond is the coverage of school-age children. What are we reaching now? And as of 2015, we're at 62%, which is a fantastic achievement. It's not the 75%, which I mentioned earlier, which is the WHO's goal and the target for worldwide treatment for school-aged children. But you can certainly see that from 2003 and even from 2012, we've increased quite significantly there. And this is the evidence of some of this. Earlier this year, India, the government of India, actually had the largest national deworming day ever globally, and 340 million children received deworming tablets on the same day, which is just a fantastic achievement. And we're seeing larger scale national programs more and more around the world for this. So what's next? How can we go beyond this? How can we get that 62% up to 75%? And it's important to look at other ways that we can perhaps harness activities that are already happening. Can we integrate with other NTD programs? Already the government of Ethiopia is talking about integrating with trachoma, perhaps, who's doing a community-based distribution, and lymphatic filariasis and onchocerciasis are also favoured. If these teams of drug distributors are already going out to the communities, how can we get them to deliver multiple things at once under one training, under one umbrella? It's also possible to integrate with other existing health interventions. Many countries, as part of maternal health days, are distributing vitamins and vaccinations, and deworming can be part of that. And finally, there's other delivery mechanisms, and one of PCD's major partners has been the World Food Programme, and they've been very on board with deworming, acknowledging that deworming can actually serve to improve the actual effects of their own feeding. In terms of reducing the morbidity and the associated pathologies that you get with soil-transmitted helminths. WFP as well, as I'm sure you'll know, often work in emergency situations, and they are very well, they're very adept at getting out to the hardest to reach areas, and really going that last mile for that coverage. So they're a very good partner to have. So beyond the control, what we're finding now, my little bit of mathematical modelling, and this is done by Roy Anderson's group in the London Centre for NTD Research. And some of the models that he's done based on the data in terms of coverage and what we need to get that STH control is actually showing that we might need to go beyond 75% in order to actually have a long-term impact. The green line here is what happens in a 75% coverage scenario, and the blue line is going up to 80%. And you can see that after five years worth of deworming, it's predicting a bounce back and a reemergence of infection almost to previous levels. If we reach the 80% level after 5 years, we're likely to see what's called breakpoint and elimination of STH as a public health problem. So I think that's quite a key bit of information. On the right as well is the number of rounds of 6-monthly treatment in order to reach Ascaris elimination. The coverage of school-aged children in this table is deemed to is 75%. And the key thing to see here is that without actually expanding treatment to include adults and preschool-aged children, this red line here is it won't happen, basically. And we'll have to continue deworming indefinitely. So this is kind of the next phase of deworming. If we can reach 75%, can we raise it up? Can we cover more? Can we actually get to a point where we don't need to do the annual deworming anymore? So bringing it right back to the beginning, the schools, PCD is a firm advocate as the school is a way to actually achieve many of the global goals. And there are, I'm sure you know, 17 Sustainable Development Goals. And we're keen to say that the school is actually able to support all 17 of those goals in its own individual ways. So I think that's something to think quite strongly about. And the school as well, it's the centre, it is the heart of the community. So it really can expand that treatment and support to reach that 80% through not only targeting the school-aged children, but perhaps treating the people who work in the schools, the teachers, the clinicians, the nurses, the cooks, and as well serving to get those messages back home, back to the communities, and really raising the awareness and the importance of this activity. So thank you. If you want to find out more about any of this, please see the sites, londonntd.org and Schools and Health. So thank you.
one of the sort of slides about India having to set up some number, 100 number of monitoring centres to look for adverse events and things like that. And it wasn't something that crossed my mind, but of course if you're giving drugs and it's pretty safe to all of the population, that becomes an issue in these mass treatments.
In terms of, I mean, yeah, you're absolutely right. And India was very cautious, and it's you know, kind of what we advocate for as well is that if you are doing that amount of deworming, you don't anticipate side effects, but there will be some, even if it's completely unrelated, those adverse events. And so it's very important to have the understanding of the community and to make sure the community feels safe and that they know that that you know, kind of the government and the people doing this have got a strategy in case something does happen. And there have been, I think, incidences in the past, you know, 10, 15 years ago. I think in Ghana there've been incidences in some of these areas where something bad does happen that might be completely unrelated to the actual taking of the tablet, but it just smears the whole campaign, and we have to be very careful about that.
It's really the key thing that Laura's just mentioning. They never really thought. So 7. And the nurse said, I think that
Yes. Oh, hi, good afternoon. My name is Dalton Booker. I work in the data. My interest in this is that I'm from Sierra Leone in West Africa, which, if you know anything about, well, it's the source of blood diamonds, and we had the Ebola crisis. However, I'm an ex-medical student in Sierra Leone, and while I was a medic, stroke paramedic, 90% of my work was dealing with malaria, cholera, HIV, and diarrhea, dysentery. That was like 90% of my work, of our work as medical students, stroke paramedics, stroke doctors. There's very few, relatively very few road traffic accidents in Sierra Leone, not because the roads are in good condition, but because the drivers are very careful. They've got this, instinct of survival. They don't want to die. So it's basically, my question is, what can be done in a country like Sierra Leone, which is the world's 10th poorest country and has one doctor for every 150,000 people, one nurse for every 15,000 people. What can be done in such a resource-poor country to improve standards in terms of, like, we've got the world's highest under 5 mortality rate and the world's highest. In general, what can be done in such a resource-poor country to improve health outcomes?
I can answer part of it, and kind of from PCD's point of view, this is where we would advocate very much for school health and nutrition. The health systems in Sierra Leone are massively under-resourced and overburdened. Exactly. So being able to work with education to be able to actually address some of these simpler things, which do have an impact on development and on the development of the economy, as well as development of the children themselves and their long-term productivity. Being able to really support that in whatever way possible is really key to a longer-term kind of strategy there. I think it's also a place where you'd probably advocate for some of these NGOs to perhaps come on board with the governments to really support some of these activities as part of their existing activities. So if they're already delivering food to certain areas, can they just chuck on the
so I don't
worms?
interrupt you, but in Sierra Leone, the politicians are just fantastically corrupt. The civil servants are horrendously incompetent, and the teachers and lecturers are on strike 3/4 of the time.
Right. Yeah, and then having the schools on strike. And I used to work in Zimbabwe about 10 years ago, and we went into the schools to do the school-based deworming and this, kind of take these samples. And the teachers were on strike. They hadn't been paid for 6 months. They did still come in. I don't know what the situation would be in Sierra Leone. They saw this as something which could still benefit the children. They still cared about their jobs. If that's not the case, I'm afraid my expertise is not within policy, global policy. Leslie, I don't know if you've got experience in that kind of arena.
So Sierra Leone, specifically, they're strengthening their policy. On contract.
What's that? You mean theft?
Theft, corruption, all of those things. And it's gone down like cash transaction.
My cousin is the Deputy Auditor General in Sierra Leone. During the Ebola crisis, $127 million went missing.
Yeah, can well imagine.
That's the level of corruption we're talking.
Health is a very complicated subject. Any other?
Short answer, no. At least in the human population, it does occur in the veterinary world. But in the human population, we've never actually managed to reach, for one, the level of drug pressure that would be required. So in the veterinary world, where you see the resistance occurring, it's when you're treating 100% of your animals 3 times over, in the same field. So they're just, it's just a higher pressure to see that resistance emerging. In humans, it's not really been seen. Leslie, I think you used to work, no? There's beta tubulin as a mechanism. Is that seen in humans actually in the?
There's no trigger. There's no actual evidence of resistance.
the strategy that General Joseph Lago adopted in South Sudan when he was head of the Anyana. He had his guerrilla army, and he told me that he kept them healthy with his wife's family. Western medicine. He said that, yeah. Dosed the fellow, and they were able to continue. I mean, his diary was so acute. So I do feel it's very well worthwhile. That every single medical a wealth of with people in the ground.
Because of the model that you showed there, improving hygiene. The prevalence compared to the drugs that you explained.
Yeah, that's a good question. So it's widely acknowledged that the transmission of these infections is via poor sanitation and hygiene. Unfortunately, the data is not being so forgiving, and even with very large studies of collecting this data on hygiene, I mean, how do you know, the measurement of hygiene and those actual metrics might be part of the issue there. But even with large studies, they're not finding a causal link, a definitive causal relationship or even association. And that's, sometimes it goes one way, sometimes it goes the other. I've seen one study where it says hookworm infection goes up in the presence of latrines, another one where, ascaris does go down in the presence of hand washing. I think, we do advocate for water, sanitation and hygiene. I mean, that's a human right, and it's, just, especially in schools, I can't see how all these children can go to school without a toilet or without enough toilets, or without being able to wash their hands before they eat their food. These are kind of basic things that we need to be aware of, and we do advocate for that. Unfortunately, at the moment, we're still waiting for that amazing data set to be able to point and say, listen, now you need to really invest in this.
So, a lot of you guys have spoken about like targeting. Do you ever feel that children could be overloaded?
But I think that's exactly why we work with governments and make sure there's an umbrella, that it's not just this, that, the other coming from every single direction. If you've got an umbrella and a strategy and an ability to understand what the priority things are for that area, then you can really target in a much more effective manner than, like you say, doing everything under one thing and then you're expected to go learn maths for like 45 minutes in the day. That's not going to work. So it is understanding that there will be a tipping point. Hopefully, and usually the government understands that, the Ministry of Education is very aware of, this is something they can support, but only to a certain extent. So.
Many thanks. I just tremendously thank all the speakers.